Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine at Mustansariya University. In this talk, the pathology of heart diseases will be outlined, especially from its practical point of view. Accordingly, the causes, morphology, and clinical presentations of different heart diseases will be addressed herein. As you know, the normal weight of the heart is 250 to 350 grams. The normal thickness of the left ventricle is 1.3 to 1.5 centimeter, and the normal thickness of the right ventricle is zero point 0.3 to zero point 0.5 centimeter. Accordingly, higher weight or ventricular thickness signifies hypertrophy, whereas below normal weight signifies atrophy. Start with the heart failure. It is the end stage of all forms of serious heart diseases. It is defined as inability of the heart to fulfill the body demands despite adequate blood volume that lead to decreased perfusion. All of it will lead to first impaired cardiac output causing fatigue. Impaired gas exchange in the lungs can cause shortness of breath. Disturbance in the heart and salt balance causing edema or change in the skeletal muscle function. Different causes of heart failure can lead to loss of myocardial efficiency, and this could lead to initiation of compensatory mechanisms, and if failed, can lead to further loss of myocardial function and eventually heart failure. The compensatory mechanisms: normally the cardiac output is 5 liters per minute. The cardiovascular system compensates for any change by first tachycardia, which means increase in the heart rate. Secondary is the dilatation of the ventricles due to increased muscle stretching, and this leads to cardiomegaly. Third is the hypertrophy, for example, right ventricular hypertrophy in pulmonary heart disease and left ventricular hypertrophy in systemic hypertension. The most common cause of left-sided heart failure are first, ischemic heart disease, secondary is the systemic hypertension, third is the mitral or aortic valve disease, and finally, primary diseases of the myocardium, for example, amyloidosis. Left heart failure can cause passive congestion of pulmonary circulation that leads to increased hydrostatic pressure and lead to leakage of fluid and occasionally RBCs in the interstitial tissue and air spaces of the lung. This is called the pulmonary edema. The RBCs will escape to the alveolar space and engulfed by macrophage, and this is called the heart failure cell, which cause cough with the blood-stained sputum. Pulmonary congestion also causes increased pulmonary vascular resistance, and this leads to increase in the workload on the right side of the heart, causing right-sided heart failure and systemic venous congestion and edema. Morphologically, as seen in this figure, which is the chronic venous congestion of the lung at high power view, you can notice the engorgement of the septal capillaries and as well as the hemosiderin-laden macrophages. The hemosiderin granules within the cytoplasm of macrophages appear brownish in color. For the clinical features of the left-sided heart failure, the patient could be presented with the dyspnea, especially during physical activity. This is called exertional dyspnea, caused by decreased lung compliance and increased activity of autonomic stretch receptors. The patient could also present it with orthopnea, which is dyspnea or lying down, paroxysmal nocturnal dyspnea, or even cough, which is sometimes bloody. Cerebral hypoxia can occur and cause coma, uh, and finally, decrease in the renal perfusion can lead to the stimulation of renin-angiotensin-aldosterone system and causes the sodium and water retention, so the patient could be presented with the peripheral edema. It is important to know that the chronic left ventricular failure will lead to right ventricular failure later on. As a compensatory mechanism, the left ventricle is markedly thickened in this patient with severe hypertension that was untreated for many years. The myocardial fibers have undergo hypertrophy as a consequence of the increased pressure load. The left ventricle is over 2 centimeters in thickness, and the weight of the heart consequently increased to over the normal of 350 grams, sometimes up to 800 grams. The other form is the right-sided heart failure. It usually occurs as a consequence of left-sided heart failure. As I said, it is the most common cause. In addition, isolated right-sided heart failure is infrequent and typically occurs in patients with one of a variety of disorders affecting the lungs, the parenchymal lung disease. Hence, it is often referred to as carpopulmonale. The carpopulmonale stands for the cor is the heart, while the pulmonale is the lung. So it is the pulmonary heart disease is the disease of the right side of the heart resulting from the disorders of the lungs. It is characterized by right ventricular dilatation or hypertrophy or both. The third cause of the right-sided heart failure could be the carpopulmonale, also may arise secondary to disorders that affect the pulmonary vasculature, for example, primary pulmonary hypertension. The major morphological and clinical effects of pure right-sided heart failure differ from those of the left-sided heart failure in that, first, engorgement of the system and portal venous system typically is pronounced. Secondly, the pulmonary congestion is minimal. Morphologically, the liver is showed passive venous congestion, causing a grossly mottled appearance similar to the nutmeg, hence the name nutmeg liver. Here is an example of a nutmeg liver seen with a chronic passive congestion of the liver as a consequence of right-sided heart failure. Note the dark red congested regions that represent accumulation of RBC in the centrilobular region, the central venules. Sometimes, especially if left-sided heart failure is also present, there will be sinusoidal congestion with centrilobular necrosis and with the chronicity centrilobular fibrosis. This is called cardiac cirrhosis. Clinically, the clinical presentations are related to systemic and portal venous congestion, as right-sided heart failure can lead to systemic venous congestion and edema, and include first hepatic and splenic enlargement, peripheral edema. Thirdly is the pleural effusion and ascites. Next is the venous congestion and hypoxia of the kidney and brain due to right-sided heart failure can produce deficit, which is comparable to those caused by the hypoperfusion of the left side of heart failure. And finally, as the congestive heart failure progresses, patients may become frankly cyanotic and acidotic. Another heart disease that tries to cover in this presentation is the congenital heart diseases. They are abnormalities of the heart or great vessels that are present at birth. The cause is unknown in almost 90% of cases. The accepted etiologic factors are first environmental exposures, including congenital rubella infection, teratogenes, and maternal diabetes. Secondary is the genetic factors. Based on the hemodynamic and clinical consequences, the congenital heart diseases can be first, malformations causing a left to right shunt, for example, ventricular septal defect, atrial septal defect, and patent ductus arteriosus. You need to know the direction of the blood flow as indicated by the arrows. They are associated, at least initially, with the cyanosis. However, prolonged left to right shunting may eventually give rise to pulmonary hypertension and can cause shunt reversal, right to left shunting of the unoxygenated blood into the systemic circulation, a change marked by the appearance of late onset cyanosis, and this is called Eisenmenger syndrome. Secondary is the malformations causing a right to left shunt. This is called cyanotic congenital heart diseases, including tetralogy of Fallot and transposition of great artery. With right to left shunt, a dusky blueness of the skin, called cyanosis, results because the pulmonary circulation is bypassed and poorly oxygenated blood collected from the venous system enters the systemic arterial circulation. There is also the third, the malformations causing obstruction, taking the coarctation of aorta as an example. Here is a heart with both an atrial septal defect and a muscular ventricular septal defect. The heart is opened on the left side with the left ventricular free wall reflected superiorly to reveal two defects, as denoted by the arrows, including both an atrial septal defect and a muscular ventricular septal defect. Such small defects do not produce significant left to right shunting, but they do increase the risk of infective endocarditis, and a hollow systolic murmur may often be audible on auscultation of the chest. As you know that the ventricular septal defect, it causes the left to right shunt, and this leads to right ventricular hypertrophy and dilatation. The pulmonary artery dilated due to increased volume ejected by right ventricle and vascular changes of pulmonary hypertension commonly seen. The clinical presentation of the ventricular septal defect depends on the size. So for a small ventricular septal defect may be asymptomatic and close spontaneously during childhood. The larger defects can cause left to right shunt, causing pulmonary hypertension, whereas the reversal shunt occur early and more frequently than atrial septal defect, so early surgical correction is indicated. A majority, 90% of atrial septal defects are so-called ostium secundum defects, in which growth of the septum secundum is insufficient to occlude the second ostium. Other types are ostium primum atrial septal defect, which accounts for 5%, sinus venosus, either superior or inferior ASDs, and coronary sinus defects. The ASDs it cause left to right shunt after birth due to lower pressure in pulmonary circulation and right side of the heart. Even larger lesions produce no symptoms in childhood because the flow is from left to right. The atrial septal defects, which are less likely to be spontaneously closed, are the most common defects to be first diagnosed in the adults. With time, pulmonary vascular resistance increase lead to pulmonary hypertension and can cause reversal shunt with shunting of the unoxygenated blood to the systemic circulation, manifested by cyanosis and congestive heart failure. This is called Eisenmenger syndrome. Moving to the cyanotic heart disease, which includes the tetralogy of Fallot and transposition of a great artery. The tetralogy of Fallot is the common congenital right to left shunts. As seen in this figure, you should notice the arrow which indicates the direction of the blood flow. The tetralogy of Fallot, which accounts for 5% of all congenital malformations, consists of four components as seen in this figure. First is the pulmonary stenosis, right ventricular outflow obstruction. Secondly is the right ventricular hypertrophy. Third is the ventricular septal defect. And finally, overriding of the aorta, which means the aorta is positioned directly over the ventricular septal defect. The morphology: a large boot-shaped heart because of right ventricular hypertrophy. Clinically, the extent of the shunt, the clinical severity is determined by the degree of pulmonary stenosis. Accordingly, mild stenosis resembles ventricular septal defect because of high pressure on the left side, causing left to right shunt and no cyanosis. Marked stenosis causes significant cyanosis early in life. The lung protected from hemodynamic load by pulmonary stenosis and pulmonary hypertension not developed. The patient develops erythrocytosis with attendant hyperviscosity and hypertrophic osteoarthropathy with increased risk of infective endocarditis, brain abscess, and systemic emboli. For the transposition of a great artery, as seen in this figure, with and without ventricular septal defect. The pulmonary artery arises from the left ventricle and the aorta arises from the right ventricle. There is separation of the systemic and pulmonary circulation, which is incompatible with life unless there is some shunt through ventricular septal defect, atrial septal defect, or patent ductus arteriosus. It results from failure of proximal aorta and pulmonary artery to undergo rotation. Even with stable shunting, most uncorrected transposition of great artery patients still die within first months of life, so they undergo corrective surgery within weeks of birth. Thirdly is the malformations causing obstruction, taking the coarctation of the aorta as an example. It is more common in male than in female. It may be associated with secular aneurysm of the central nervous system. It occurs frequently with Turner syndrome. It is morphologically of two types. First is the preductal or infantile form, seen in the left image. Secondary is the postductal or the adult form. For the preductal form, there is a narrowing of the aortic isthmus, the region between left subclavian and point of entry of the ductus arteriosus. The patent ductus arteriosus, as seen in this figure, which is the source of blood delivered to the distal aorta. Accordingly, right heart perfuses body distal to the coarctation, and this leads to right ventricular dilatation and hypertrophy, along with pulmonary trunk dilatation, which is seen in this figure, to accommodate increase in the blood flow. Clinically, the patient could present in infancy with the congestive heart failure. The important Clinical feature is the selective cyanosis of the lower limbs because of the perfusion by poorly oxygenated blood via ductus arteriosus. The femoral pulse will be weaker than those of the upper limbs. The patients not survive in neonatal period without surgical correction. The second form is the postductal or adult coarctation. The aorta constricted just distal to the obliterated ductus arteriosus. Proximal to the coarctation, the aortic arch and its branch vessels are dilated, and the left ventricle is hypertrophied, as seen in the figure. In addition, the collateral flow through intercostal epigastric arteries and supply blood to the distal aorta. Clinically present in children and adults because blood reaching distal aorta comes from collateral. That means oxygen content is normal and selective cyanosis is not seen here. Hypertension of the upper limb in most cases is due in part to renal hypoperfusion. In addition, systemic blood pressure is low and pulses are weaker in lower limbs, associated with signs and symptoms of arterial insufficiency, for example, intermittent claudication. This figure shows chest X-ray finding in postductal or adult coarctation, including the rib notching and figure 3 sign. Expansion of the flow through collateral vessels can lead to radiologically visible notching of the ribs, as indicated by the arrows. Other radiological sign occurs in addition to rib notching called the figure 3 sign, which appears to the left of the mediastinum and is caused by pre- and post-stenotic dilatation of the aorta. The topic is ischemic heart disease. It is a broad term containing several closely related syndromes caused by myocardial ischemia, an imbalance between cardiac blood supply, the perfusion, and myocardial oxygen and nutritional requirements. The clinical presentation of ischemic heart disease may include one or more of the following cardiac syndromes. First, angina pectoris. Secondary is myocardial infarction. Third is the chronic ischemic heart disease with congestive heart failure. And finally, sudden cardiac death. The term acute coronary syndrome is applied to any of the three catastrophic manifestations of ischemic heart disease, including unstable angina, myocardial infarction, and sudden cardiac death. I will talk about the myocardial infarction in more details. The myocardial infarction indicates development of a defined area of myocardial necrosis caused by local ischemia. For the pathogenesis, mostly caused by coronary artery thrombosis, in which pre-existing atherosclerotic plaque play important role. There is disruption of atherosclerotic plaque with fissure formation, which serves as nodes for thrombus. Other symptom causes are vasospasm and embolization from neural thrombi, for example, in atrial fibrillation or from valve vegetations. Myocardial infarction begins within 20 to 30 minutes of coronary artery occlusion in the subendocardial region because it is the least area to receive blood from coronaries, then extend peripherally, reaching full size within 3 to 6 hours. During this period, lysis of the thrombus by thrombolytic agents may limit the size of infarct. For the morphology, it depends on the age of the injury. Areas of the damage progress through a sequence of morphologic changes, from coagulative necrosis to acute and then chronic inflammation to fibrosis. It proceeds invariably to scar formation without any significant regeneration, as seen in this figure of recent myocardial infarction by 3 to 7 days. The center of the infarct contains necrotic muscle that appear yellow tan, as indicated by the white arrow. Surrounding this is a zone of red hyperemia, which is indicated by the yellow arrow. Remaining viable myocardium is reddish brown in color. The evolution of gross changes after myocardial infarction is as follows. In less than 4 hours, there will be no changes. By 4 to 24 hours, dark mottling will appear. With the 1 to 3 days, the infarct center will become yellow in color. By 3 to 7 days, hyperemia at the borders will appear, as seen in the previous figure. The 7 to 14 days, the red-gray and depressed borders will appear, and by 2 to 8 weeks, gray-white granulation tissue will be noticed. Finally, with time greater than 2 months, there will be complete scarring formation. This is the normal microscopic appearance of cardiac myocardial fibers in longitudinal section. It shows the central nuclei and the syncytial arrangement of the fibers, some of which have pale pink intercalated discs. As I said, depending on the age of the injury, area of the damage progressed through a sequence of morphologic changes from the coagulative necrosis to acute inflammation with a neutrophil infiltrate, and then chronic inflammation with macrophage infiltrate to fibrosis. It proceeds invariably to scar formation without any significant regeneration. This is the figure with microscopic features of myocardial infarction and its repair. Figure A is 1 day old infarct showing coagulative necrosis and wavy fibers compared with adjacent normal fibers on the right. Necrotic cells are separated by edema fluid. Figure B, dense neutrophilic infiltrate in the area of a 2 to 3 days old infarct. You can notice in figure C there is nearly complete removal of the necrotic myocyte by phagocytic macrophage. This is from day 7 to 10. In figure D, the granulation tissue characterized by loose connective tissue and abundant capillaries. Finally, in figure E, healed myocardial infarcts consist of a dense collagen scar. A few residual cardiac muscle cells are present. The earliest change histologically seen with acute myocardial infarction in the first day is contraction band necrosis. The myocardial fibers are beginning to lose cross striations and the nuclei are not clearly visible. Pycnosis of the nuclei in most of the cells seen here. In addition, there will be hypereosinophilic appearance of the myocytes. This high-power microscopic view of the myocardium shows an infarction of about 1 to 2 days in duration. There is coagulation necrosis with loss of nuclei and striations. In addition, there is a beginning of acute inflammation with interstitial infiltrates of the neutrophils. Clinically, such an acute myocardial infarction is marked by changes in the ECG and by a rise in the troponin I and the MB fraction of the creatine kinase in the serum. The serum creatinine kinase, specifically the CKMB isozyme, more specific to the heart, and troponin I are released from damaged myofibers and start to increase 3 to 4 hours after the initial ischemic events. CKMB peaks about 1 day later, then declines to negligible levels by third days. The troponin I level remains increased for 10 to 14 days. Serum myoglobin can be increased starting 3 hours after myocardial infarction, but is not specific for myocardium. This figure shows the myocardial infarction 3 to 4 days old. There is an extensive acute inflammatory cells infiltrate, as well as the coagulative necrosis with loss of nuclei and striation. With time, about 1 to 2 weeks, the granulation tissue form and characterized by lost connective tissue and abundant capillaries. As seen in this figure, there are remaining normal myocardial fibers at the top. Below these fibers are many macrophages along with the numerous capillaries and little collagenization. In this figure, there is pale white collagen within the interstitium between myocardial fibers. This represents an area of remote infarction. This image shows fibrosis with thinning of the heart wall. There has been a previous extensive transmural myocardial infarction involving the free wall of the left ventricle. Note that the thickness of the myocardial wall is normal superiorly, but inferiorly is only a thin fibrous wall. There are many complications of myocardial infarction, including first arrhythmias, the most important is ventricular fibrillation. Second is extensive myocardial infarction that could lead to left ventricular failure. Third is the cardiogenic shock. Fourth is the thrombosis. The other complication is the papillary muscle dysfunction caused by local bulging of ventricular wall, ischemia and decreased contraction of the papillary muscle, and generalized dilatation of the ventricular wall in heart failure. The other complication that I will talk in this slide is the rupture of the myocardium. The other complication is the cardiac aneurysm. I will talk about it in the next slide. The pericarditis and post-infarction syndrome, which is called the Dressler syndrome, is another complication of myocardial infarction. In this figure, shows the complication of myocardial infarction, which is the rupture of the myocardium. Mostly occurs between the 3 and 7 days after infarction. This is due to local bulging of ventricular wall, so there will be either rupture of the left ventricular free wall, which is the most common, lead to hemopericardium and cardiac tamponade. This is seen in figure A. In figure B, you can notice the rupture of the ventricular septum leading to ventricular septal defect with left to right shunting. The figure C shows the papillary muscle rupture leading to severe mitral regurgitation. As I said, one complication of transmural myocardial infarction is rupture of the myocardium. This is most likely to occur in the first week between 3rd to 5th days following the initial event, when the myocardium is the softest. The white arrow marks the point of rupture in this anterior-inferior myocardial infarction of the left ventricle free wall and septum. Note the dark red blood clot forming the hemopericardium. Here is the cross-section through the heart reveals a ventricular aneurysm, which is another complication of myocardial infarction, with a very thin wall at the arrow. Note how the aneurysm bulges out. The stasis in this aneurysm allows mural thrombus, which is present here to form within the aneurysm. The ventricular aneurysm is a late complication, which is the bulging of non-contractile fibrous myocardium during systole, result from a large transmural anteroseptal infarct that heal with the formation of a thin wall of scar tissue. It is very important to know that the consequence of the ventricular aneurysm. It frequently gives rise to the formation of mural thrombi, arrhythmias, and heart failure, but it do not rupture. Next subject is the valvular heart disease. I will talk about the rheumatic valvular disease and infective endocarditis in more details. Acute rheumatic fever is acute immunologically mediated multisystemic inflammatory disease that follows after a few weeks an episode of group A streptococcal pharyngitis beta hemolyticus. Rheumatic heart disease is the cardiac manifestation of rheumatic fever and is associated with the inflammation of all parts of the heart, including valves, myocardium, or pericardium. But valvular inflammation and scarring, rheumatic valvular disease produce the most important clinical features. For the etiology and pathogenesis, it is not caused by direct infection by the microorganism, but it is due to streptococcal antigen. For the mechanism, the rheumatic fever is hypersensitivity reaction induced by antibody directed against M proteins of streptococci cross-react with tissue glycoprotein in the heart, joint, and other tissue. Similarity between streptococci and cardiac antigen, this is called type 3 hypersensitivity reaction. In addition, cardiac lesion could be due to type 4 hypersensitivity reaction. This is called the cell-mediated immunity. For the morphology, the pancreatitis, which is the inflammation, changes in all three layers. That means the pericardium, myocardium, and endocardium. For the pericarditis, there will be fibrinous pericarditis with the serous or serous-albuginous pericardial effusion, described as bread and butter pericarditis. In myocarditis, there is acute fatal cases, in which there will be flabby myocardium as well as left ventricular dilatation. In addition, tiny pale foci, just visible, called the Ashov bodies, which are pathognomonic of rheumatic carditis, mainly in the left atrium and ventricle, but can be found in any of the three layers of the heart, including the valves. For the endocarditis, it shows diffuse edema as well as slight cellular infiltrates. The Ashov bodies present numerous in the posterior wall of the left atrium. Healing will lead to irregularity of the endocardium called McCallum patch. Regarding the heart valves, mitral and aortic are commonly affected. For the morphological features of acute rheumatic fever, as shown in this figure, the small verrucous vegetations seen along the closure line of this mitral valve are associated with acute rheumatic fever. These warty vegetations average only a few millimeters and form along the line of valve closure over areas of endocardial inflammation. It consists microscopically of fibroblasts, neutrophils, and Ashov bodies. It may resolve without sequelae or cause scarring and significant deformities. So the vegetations are sterile and do not cause destruction of the valve. Microscopically, acute rheumatic carditis is marked by a peculiar form of granulomatous inflammation, so-called Ashov nodules, seen best in myocardium. These are centered in the interstitium around vessels as shown here. The Ashok-Badi's tiny pill foci are pathognomonic of rheumatic carditis, mainly in the left atrium and ventricle, but can be found in any of the three layers of the heart, including the valves. It is defined as multiple foci of inflammation containing central focus of fibroid necrosis surrounded by chronic inflammatory cells and occasionally activated macrophage with vesicular nuclei and abundant basophilic cytoplasm. This is called Henchkov cells. They present in close proximity to small vessels. If Ashok bodies subside, they produce scar. Here is an ash of nodules at high magnification. The most characteristic cellular component of this Ashoff nodule is the Ashoff giant cell. These appear here as large cells with two or more nuclei that have prominent nucleoli. Scattered mononuclear inflammatory cells accompany them and can be occasionally neutrophils. This high magnification view shows Henchkov cells as activated macrophages, has abundant basophilic cytoplasm with prominent nucleoli and central wavy caterpillar chromatin. Patients with acute rheumatic fever could also present with extracardiac changes. These include general clinical features as fever, malaise, sweating, increased ESR, leukocytosis. Inflammation of other size could be seen, especially in the joints and adjacent soft tissues, causing migratory polyarthritis of the large joints. The serosal surface could be involved, forming pericardial and pleural effusion. In the skin, the arrhythmia marginatum and subcutaneous nodules could be developed. As a CNS manifestation, Sydenham scoria could be observed, which is an involuntary, purposeless rapid movement of the muscle. The chronic rheumatic heart disease is the result of organization of the acute inflammation and subsequent scarring fibrosis. In particular, the valvular leaflets become thickened and retracted, causing permanent deformity. For the morphology of chronic rheumatic heart disease, as seen in this figure, mitral stenosis with diffuse fibrosis, thickening and distortion of the valve leaflets, commissural fusion, and thickening and shortening of the chordae tendineae. There is marked left atrial dilatation as seen from above the valve. In addition, fibrous bridging across the valvular commissures and calcification create fish mouth or buttonhole stenosis. Other valvular heart disease is called the infective endocarditis. The infective endocarditis is characterized by microbial invasion of the endocardium with destruction of the underlying cardiac tissues. Majority of cases is caused by bacteria, although fungi, rickettsia, and chlamydia can cause endocarditis. The endocarditis is of two types, either acute or subacute, depending on the intrinsic microbial virulence and whether underlying cardiac disease is present. For the etiology and pathogenesis, it occurs during episode of bacteremia, for example, intravenous drug abusers, tonsillectomy, infection elsewhere, in addition to previous dental or surgical procedure, for example, catheterization, and even tribal skin injury. For the conditions that increase the risk of infective endocarditis, first is the abnormality of the heart, at which any condition causes increased hemodynamic trauma to the endothelial surface, for example, ventricular septal defect, rheumatic fever, calcific aortic stenosis, or mitral prolapse. The second condition is the prosthetic heart valves, and finally, impaired defense mechanisms like immune deficiency disease and cytotoxic drugs. As I said, the infective endocarditis is either subacute bacterial endocarditis or the acute infective endocarditis. For the subacute bacterial endocarditis is caused by low virulent microorganisms, for example, Streptococcus viridans of alpha hemolytic group or Staphylococcus albus. While for the acute infective endocarditis, it is caused by highly virulent microorganisms, for example, Staphylococcus aureus or Streptococcus pyogenes or Enterococci. It is said that the acute infective endocarditis is more severe infection than subacute infective endocarditis and can be fatal without treatment. The acute infective endocarditis occurs on previous normal valves, while for the subacute bacterial endocarditis, the valve is already diseased and the bacteria adheres to the injured surface of the valve. This figure shows the infective endocarditis. The aortic valve deformities demonstrate a large irregular reddish tan vegetations as denoted by an arrow. As I said, the virulent organisms such as Staphylococcus aureus produce an acute bacterial endocarditis, while some organisms such as Streptococcus viridans produce subacute bacterial endocarditis. It is important to know the characteristic features of the vegetations of both subacute infective endocarditis and acute infective endocarditis. For the vegetations of subacute infective endocarditis, it is large size, friable, not sterile, and give rise to emboli. Microscopically consist of platelets, fibrin, and few leukocytes along with bacterial colonies. But the vegetations of subacute infective endocarditis are firmer and associated with less valvular destruction and less likely to erode the myocardium. For the acute infective endocarditis, the vegetations are larger, bulky, friable that obstruct valve orifice and cause rupture of the leaflets, papillary muscles, and cordae. The infection may extend to adjacent myocardium, lead to perivalvular abscess, ring abscess. Microscopically consist of larger number of microorganisms as well as fibrin and blood cells. More severe damage to the valve due to rapid destruction, necrosis, suppuration which extend from the cusps, cordae, myocardium, and aorta, causing mycotic aneurysm. It is important to know that aorta and mitral valve are commonly affected. The more virulent bacteria causing the acute bacterial form of infective endocarditis can lead to serious valvular destruction, as shown here involving the aortic valve. Irregular reddish tan vegetations overlie valve cusps that are being destroyed. Portions of the vegetation can break off and become septic emboli. As I said, the subacute infective endocarditis, the microscopic appearance consists of platelets, fibrin, along with a few leukocytes and bacterial colonies. While for the acute infective endocarditis, the microscopic features consist of larger numbers of microorganisms, along with fibrin and blood cells. This image shows the microscopic features of the valve in infective endocarditis, shows the friable vegetations of fibrin and platelets, which appear pink in color, mixed with inflammatory cells and bacterial colonies, which is blue in color. The friability explains how portions of the vegetation can break off and embolize. The clinical features include fever, malaise, mild anemia, and weight loss. Systemic emboli, because of the friable nature of the vegetations, can also occur, and because the emboli contain large numbers of microorganisms, abscess often develop and may lead to septic infarcts. Effects of embolization is in all forms. In kidney, it can cause renal infarcts and glomerulonephritis with hematuria. Enlarged spleen and clumping of the nails can also occur, especially in subacute infective endocarditis. There may be neurological deficit as well as retinal hemorrhage or blindness. In the skin, a petechiae may be developed, and in the nail, splinter hemorrhage may be noticed. In this picture, you can see small linear splinter hemorrhage, seen here subungually as linear dark red streaks on the left thumb of the patient with infective endocarditis. Similar hemorrhage can also appear with trauma. For the causes of death in infective endocarditis, first is the heart failure due to myocardial infarction or cusps rupture. Secondary is the renal failure. Without treatment, it is fatal, but with early treatment, the mortality decreased to 15%. Here is another marantic vegetation on the leftmost cusp. These vegetations are rarely over half centimeter in size. However, they are friable and very prone to embolize. It is non-infective, sterile, and tend to occur in persons with hypercoagulable state. The sterile valvular lesion of non-bacterial thrombotic endocarditis are non-destructive. Liebman-Sack endocarditis, another type of non-infective endocarditis, characterized by the presence of sterile vegetations on the valves of the patient with systemic lupus erythematosus. As seen in this image here are flat pale tan spreading vegetations over the mitral valve surface and even on the chordae tendineae. This patient has systemic lupus erythematosus. Subjects are myocarditis and cardiomyopathy. Myocarditis is inflammation of the myocardium with the resulting injury, usually acute serious and lead to heart failure, but full recovery is possible. Causes: first, viruses, including the Coxsackie A and B, influenza, cytomegalovirus, or HIV, usually mild and affects infants and young adult males. Second is bacteria like Staphylococcus aureus or Streptococcus pyogenes. Third is the toxin from diphtheria, typhoid, or pneumonia. Fourth cause is the immunological hypersensitivity reaction, for example, from rheumatic fever. The other cause is the Chagas disease caused by Trypanosoma cruzi, or the trichinosis caused by the Trichinella spiralis. Other is the granulomatous TB, sarcoidosis, or syphilis. However, it could be unknown or idiopathic. In this figure, this is the myocarditis. In figure A, the lymphocytic myocarditis with mononuclear inflammatory cell infiltrate and associated myocyte injury. Figure B shows hypersensitivity myocarditis characterized by interstitial inflammatory infiltrates composed largely of eosinophils and mononuclear inflammatory cells, predominantly localized to the perivascular and large interstitial spaces. This form of myocarditis is associated with drug hypersensitivity. Figure C shows the giant cells myocarditis with mononuclear inflammatory infiltrate containing lymphocyte and macrophages, extensive loss of muscle, and multinucleated giant cell. In Figure D, the myocarditis of Chagas disease is seen as a myofiber is distended with the trypanosomes as indicated by the arrow. There is surrounding inflammatory reaction and individual myofiber necrosis. In this case, the inflammation was due to disseminated toxoplasmosis from Toxoplasma gondii infection. Here is an example of a florid myocarditis. This myocarditis consists mainly of mononuclear cells, but is mixed with some scattered polymorphonuclear cells as well. The pattern was that of patchy myocarditis. The interstitial lymphocytic infiltrates shown here within the myocardium are characteristic for a viral myocarditis, which is probably the most common type of myocarditis. There is usually little necrosis. The most common viral agent is Coxsackie virus infection. The cardiomyopathy. It is a heart disease resulting from primary abnormality of the myocardium, excluded from this heart failure caused by hypertension, valvular heart disease, myocarditis, and systemic disease. It is of three types: hypertrophic cardiomyopathy, dilated congestive cardiomyopathy, and restrictive cardiomyopathy. The three major forms of cardiomyopathy are shown in this figure. Dilated cardiomyopathy leads primarily to systolic dysfunction, whereas restrictive and hypertrophic cardiomyopathies result in diastolic dysfunction. Note the changes in the atria and/or ventricular dilatation and in ventricular wall thickness. This very large heart has a globoid shape because all of the chambers are dilated. It felt very flabby, and the myocardium was poorly contractile. This is an example of cardiomyopathy. This picture is for the heart with hypertrophic cardiomyopathy. There is marked left ventricular hypertrophy with asymmetric bulging of a very large interventricular septum into the left ventricular chamber. This leads to banana-like shape of ventricular cavity on longitudinal section. The other characteristic feature of hypertrophic cardiomyopathy include the idiopathic subaortic stenosis. In addition to the systolic function is preserved but abnormal diastolic filling because of small chamber size, which leads to low stroke volume. There may be intermittent ventricular outflow obstruction along with hyperkinetic contraction that rapidly expel blood from ventricular cavities. This is hypertrophic cardiomyopathy with asymmetric septal hypertrophy. Figure A shows the septal muscle bulges into the left ventricular outflow tract, giving rise to a banana-shaped ventricular lumen, and the left atrium is enlarged. The anterior mitral leaflet has been moved away from the septum to reveal a fibrous endocardial plug, as indicated by the arrow. B is the histologic appearance, demonstrating disarray, extreme hypertrophy, and characteristic branches of the myocytes, as well as interstitial fibrosis. The figure C, the sarcomere of cardiac muscle, showing proteins in which mutations cause defective contraction, hypertrophy, and myocyte disarray in hypertrophic cardiomyopathy. The frequency of a particular gene mutation is indicated as a percentage of all cases of hypertrophic cardiomyopathy. Most common are mutation in beta-myosin heavy chain and to lesser extent myosin binding protein C, troponin T, and alpha tropomyosin. This figure shows heart with dilated cardiomyopathy, which is called the congestive cardiomyopathy. It It is regarded as the most common type, which accounts about 90% of cases, characterized by progressive cardiac dilatation and contractile systolic dysfunction, usually with concurrent hypertrophy, and is caused by first the Coxsackie B virus, alcoholic abuse, peripartum cardiomyopathy, but mostly is idiopathic. Genetic causes account for 20 to 50%, as autosomal dominant inheritance being the predominant pattern. For example, mutation of alpha cardiac actin. The X-linked dilated cardiomyopathy is caused by mutation in dystrophin. Morphologically, there is dilatation and hypertrophy of all chambers, with a fragile mural thrombi because of poor contractile function and stasis. Microscopically, some fibers are thin, others are hypertrophic. Interstitial and endocardial fibrosis may be developed. The final type is called the restrictive cardiomyopathy. It is the least common type and is characterized by decreased ventricular compliance leading to impaired ventricular filling during diastole, mostly caused by endomyocardial fibrosis, which is a disease of unknown etiology. Following is pericardial disease. Before discussing it, we need to know that the pericardium is a fibrous sac consisting of two layers, visceral and parietal layers, and containing about 30 to 50 ml of fluid. Gradual accumulation of fluid does not lead to increased pericardial pressure, while sudden and rapid accumulation will lead to increased pressure, causing cardiac tamponade, leading to low cardiac output, severe hypotension, and low pulse pressure that can cause cardiogenic shock. Acute pericarditis is an acute inflammation and is caused mainly by first infection, mostly by viruses, but also by other microorganisms, for example, pyogenic bacteria, mycobacteria, and fungi. It could occur secondary to acute myocardial infarction, cardiac surgery, radiation to mediastinum and uremia, and less commonly are rheumatic fever, systemic lupus erythematosus, and metastatic malignancy. The morphological appearance depends on the cause. In uremia, rheumatic fever, and viral infection, the exudate is fibrous with irregular surface on the pericardial surface, giving better on-bread appearance. In bacteria, fibrinopurulence suppurative, often with area of frank pus. In TB, caseous. And finally, in pericardial metastatic malignancy, shaggy fibrinous exudate and bloody effusion develop. Acute fibrinous and fibrinopurulent pericarditis mostly resolve without any sequelae. With extensive suppuration or caseation, however, healing can result in fibrosis and this lead to chronic pericarditis. In the left image, this is an example of fibrous pericarditis. The surface appears roughened from the normal glistening appearance by the strands of pink tan fibrin. In the right image, you can see a window of adherent pericardium has been opened to reveal the surface of the heart. There are thin strands of fibrinous exudate that extends from the epicardial surface to the pericardial sac. This is typical for fibrinous pericarditis. The apical surface of the heart shows a shaggy fibrinous exudate. This is another example of fibrinous pericarditis. The fibrin often results in the finding on physical examination of friction rub as the strands of fibrin on the pericardium and pericardium rub against each other. The surface of the heart with hemorrhagic pericarditis shows a roughened and red appearance. Hemorrhagic pericarditis is most likely to occur in association with metastatic tumor. Final is the tumor of the heart, and we will take the myxoma as an example. Myxoma are the most common primary tumors of the adult heart. This picture shows the left atrium has been opened to reveal the most common primary cardiac neoplasm, which is an atrial myxoma. These benign masses are most often attached to the atrial wall, but can arise on a valve or in a ventricle. They can produce a ball valve effect by intermittently occluding the atrioventricular valve orifice. Embolization of the fragments of tumor may also occur. Roughly 90% are atrial, with left atrium accounts for 80% of cases as xylar pedunculated lesion. In addition, myxomas are easily diagnosed by echocardiography. They may also be seen with chest CT scan and with magnetic resonance angiography. The last slide is the left atrial myxoma. Figure A gross photograph showing large pedunculated lesion, most often manifesting as soft translucent with a gelatinous appearance, arising from the region of the fossa ovalis and extending into the mitral valve orifice. Figure B is the microscopic appearance, with abundant amorphous extracellular matrix, in which are scattered collections of multinucleated myxoma cells, called stellate cells, as indicated by the arrowheads in various groupings, including abnormal vascular formation as indicated by an arrow. Here is a list of references that is used in this talk. Thank you.